So, good afternoon. So I'm Enrico Martino from Italy. I'm a sports physician. So today I will speak about the use of ultrasound for the abdominal and the back region. So I have decided to organize the presentation in two parts. One more focused on the anatomy, so to recognize muscle, fascia, starting from the Linea Alba and moving to the back. And the second part will be focused more how we can use the ultrasound in rehabilitation. I guess you know that pain, immobilization, deloading, repetitive movement cause a poor control of posture and movement. And so we have evidence that retrain the optimal movements we have very good outcome in people with chronic musculoskeletal disorders. So the ultrasound could be a very useful device, a tool to improve this treatment, this type of treatment, because this give us the opportunity to see on real time the contraction of the muscles. So in my opinion, ultrasound is very useful because first is very useful for us, for the therapists, because we can see the contraction, so we can check if the suggestion that we are using to the patient to activate a muscle is performed correctly, or we need to change the cues. And the second reason is because the patient can see the contraction on the screen. So to see a contraction help to the motor learning and in particular the motor retention. So if our purpose is to change how people move because they have a poor control of the posture and the movement, it's very important to be sure that the information that we give are useful for them to improve, to learn, and to remember the exercise. So we will start with the anatomy. I will start from the midline. So normally, I put the probe in the middle of the abdominal wall, and here I can see some movement, and this is the intestine. So I'm sure that if I move a little bit higher, I will find the Rectus Abdominus muscle, and this white line is the Linea Alba. On the Linea Alba, we can see some subcutaneous tissue and the skin. So the first things that I need to do is to take some measurements of the Linea Alba, because in normal people it's below 2 centimeters, but if there is a diastasis, it could be more than 2 centimeters. And the Linea Alba is the insertion of the aponeurosis of obliquus externus, internus, and transversus abdominis. So if I want to retrain this muscle, I need to be sure that all connective tissue are normal. On the side, I can see two muscles, and this is the rectus abdominis muscle. So if I move to a direction, I can recognize, this muscle here is the rectus abdominis muscle, and this is a very typical transverse image of a muscle with the fibers like dot and line. So if I turn 90 degrees my probe, I can recognize the perimysium has lines, and if I move up, I can see the tendinous intersection that normally we have 3 or 4 in the abdominal muscle, so I can check if I can see this tendinous part. If I come back to transverse position and I start moving more laterally, I can recognize 3 muscle structure. So I can see here my intestine. And this first muscle here is the transversus abdominis muscle. The second one is obliquus internus. And the last one is obliquus externus muscle. And here subcutaneous tissue and the skin. So if I want to see in the sagittal plane my obliquus externus muscle, I need to turn a little bit my probe from we know that the origin of the muscle is the lower 6A ribs, and the direction is to the linea alba, to the pubis, to the inguinal ligament. So I can see the perimysium has lines. If I want to see the obliquus externus, I can turn my probe 90 degrees, and now I can see the perimysium has lines, and so I can recognize the direction of this muscle. For the obliquus, for the transversus abdominis muscle, the direction is from the back to the front, so I just need to change a little bit to have the perimysium. If I move more posteriorly, I can recognize the end of transverse abdominis muscle with the fascia, the obliquus internus and externus. So now, can you just move on your side? Okay, I will start again from, so the linea alba, rectus abdominis muscle, linea semilunaris, the three muscle, obliquus externus, internus, and transversus abdominis. So now I'm moving back to the back, and I can recognize another muscle here, another muscle here. These two muscles are Quadratus lumborum muscle and psoas major muscle. And here I can recognize a little bit the bone is the lateral part of the body of a vertebra. So can you just move, flex your hip and relax. Again, a little bit stronger and relax. So what I'm doing, I try to see better as possible the movement of psoas major muscle. Can you perform again? And relax. Again. And relax. Again. And relax. Okay. So here is psoas major muscle. And this bone here that we can see here is the tip of the transverse process of a lamina. So here is the bone. Now I need to optimize with my probe, and I can see the transverse process until here. So the muscle here is the rectus spinous muscle. But to study this muscle, I prefer to move the patient on the back. Yeah, that's great. So normally I start to analyze the muscle where I can recognize easily the structures. So I like to start with the probe in transverse plane on the sacrum. Sacrum is quite easy to recognize because we can see the body of the sacrum and the crest of the sacrum. And the two muscles here are the multifidus muscles. So now I can turn 90 degrees my probe, and I can see my sacrum here, and here I can recognize another bone structure with a joint here, and this is the joint, the zygapophyseal joint between S1 and L5. So if you put two pillows under the belly of the patient, you can open this space, and so you can see a lot of better this image. So here we can recognize other bone structure, and this is the lamina of L4, so L5, L4, L3, and we can go up L2. So now the lumbar lordosis is over, and we can start with the kyphosis. So here we can recognize a little bit better the structure. So lamina, L1, L2, and here is the joint. So I start again from the sacrum, and I will stop around L3. So now I'm in the transverse plane, and I can see here my spinous process. I can feel with my finger, or I can feel with my probe. The bone go down here to the lamina, so the bone became black. So if I push a little bit with my probe, I can try to have a little bit white, but the problem is the direction of my ultrasound waves are out from my probe, so I cannot see very well here the bone. So the first muscle that I can find here is the multifidus muscle. I know the rectus spinous muscle is a big muscle composed with three different muscles: multifidus, longissimus, and iliocostalis muscle. It's not easy to recognize, so I want to move a little bit lower. Yeah, maybe it's here. It's easier to recognize. So now I have my spinous process here, my lamina, and this is the transverse process and the tip of the transverse process. So this muscle here is my rectus spinous muscle, and here I have multifidus here. Can you just move your hip and relax? Great. And relax. Relax as much as possible. Okay. So here I can recognize the multifidus. Here is the border between multifidus and longissimus. And if I ask her to contract again the hip, can you move? Okay, we can see that these two muscles here, and here there is another muscle, they move in different plane. And relax. Relax. And again. And relax. So multifidus muscle start from here, go down here, the lamina. This is the lateral border, and this is the superior border. This muscle here is longissimus, and this muscle here is iliocostalis lumborum muscle. If I move a little bit more laterally, I can recognize this muscle here, and this muscle here is Quadratus lumborum muscle, and I can recognize some movement. I can see some movement here. It's the intestine, and so I'm sure that this is Quadratus lumborum muscle. So now we can move to the second part. So now I will show you first an activation of Transversus abdominis muscle, so a selective contraction of this muscle, and after we will move to some more functional movements. So before start the presentation, I spent around 10 minutes explaining her how to activate this muscle. So now she is able to do that, but just to tell you, I asked her to imagine a cable that connects the two anterior SIS and imagine to tense this cable. So this is the cue that I use, but in literature you can find a lot of different cues that you can use. You can ask them to draw the abdominal wall in, or to imagine a cable from here to the floor. Some people suggest to us to imagine to contract the pelvic floor muscle. So we can use different cues. Normally I start with this. So breathe in, breathe out. So here is transversus abdominis muscle. Okay, now she's performing the contraction. You can see the muscle increase the thickness and relax. So breathe in, breathe out, and imagine the cable with perfect. So what I need to check from this image is that I have movement just in this muscle here, and I have no movement of the other two muscles. So with the ultrasound, it's very easy to see the contraction of obliquus internus muscle, but it's very difficult to see obliquus externus. And this is the reason why I put my hand here to feel if there is activation. So here is the origin of the obliquus externus. So if I put my finger here, I can feel if she is contracting the muscle. Breathe out. Very good. So keep this contraction. So now we can see the muscle is contract and the fascia here is in tension and relax. And now the fascia is relaxed. So this fascia will arrive to the linea alba in this direction. And from the other direction, this line will arrive to, I don't know if I'm able to show, but to the tip of a vertebra. So it's the same anatomy on the other side. So if she's able to contract this muscle is like a corset for our back, and so give stability of the lumbar and lumbar area. So can you perform again? So breathe in, breathe out, stop breathing, and contract. Very good. Keep this contraction. And now breathe in gently, keep this contraction, and breathe out, keep the contraction. Very good. And again, breathe in, and breathe out, and relax. Very good. So she is able to keep this muscle contract during the respiratory cycle. So it's very good. So now we move to another exercise. Can you bend your knee? So now I will ask her to move this leg up, so flexion of the hip, because I want to create a perturbation for the back. So I want to be sure that she's able to activate, to keep this muscle on during a perturbation. So can you breathe in, breathe out, and stop breathing. Okay, very good. And now start moving. Yeah. What I need to check if, so she's able to keep the contraction here and there is not activation of the other muscle. There is not a big activation because, of course, we have a little bit activation because there is a perturbation. So other muscle need to stabilize. But what I'm interested is that the deeper part, the transversus abdominis muscle, is on during the movement. So breathe in, breathe out, stop breathing, keep this contraction, and yes. Of course, during rehabilitation, you can use different type of perturbation. You can ask to move and harm. It's in accordance with your clinical examination. And now we can perform another exercise, a more functional exercise. It's a semi-squat exercise. So I need to put some gel. Okay. So now here is the posterior part of transversus abdominis, as this is the fascia will arrive to the lumbar vertebra. So now I ask her to breathe in, breathe out. So, yeah, stop breathing. Very good. And now we can start, so squatting and come back. So is important that this muscle, and you can relax, it's important that transversus abdominis will be on during the exercise, during this functional movement. Again, breathe in, breathe out. Very good. Keep this contraction and start. And come back. And relax. Okay, now we can try with just one leg, so a squat in one stand, one leg. So breathe in, breathe out, stop breathing, keep this contraction, and relax. So here it's important to check that transversus abdominis is on. Of course, we have obliquus internus is on too because they need to control the movement of the pelvis. Okay, we have, I think, 5-10 minutes for some questions. Do you have any question?
What do you do when a patient is not possible to contract transversus?
So normally, after my clinical examination, if from my clinical examination there is a poor motor control of this muscle, I start lying down as today. I give the feedback on the screen. I explain a little bit what I want. I start using different cues, using these cables. Imagine a cable from here to here, or from here to the hip joint. So I try to use several to see which one could be better. And after I give the feedback to the patient to improve the contraction of this muscle. And once that the patient is able to do that, I will start using some perturbation. So start moving your leg. So normally I try to, if it's possible, if I'm able to do a very good clinical examination, I can understand, for example, is rotation syndrome. For one side, I try to be very focused on a treatment in that direction as soon as possible. So I try to personalize treatment to the problem. So from a clinical examination, I can see in which plane they have problem, and I try to work to optimize at the beginning in that direction. Also, if other directions are not good, but if they are not painful at the beginning, I don't mind, because it's better that they feel better at the beginning, and after I try to work to optimize different movements. So bend forward, or it depends.
You're looking also the difference between left and right?
So yeah, so normally I like to take measurements of muscles. In particular, from my clinical examination, I can see that there is a shift of the one side, there is a scoliosis, and so I can hypothesize that there is some hyperactivation of some muscle in a direction. So I like to take measurements and to compare after a treatment if there is differences or not. And sometimes if I can find, for example, if I have a patient with scoliosis and I can check that obliquus externus of the left side is contract and obliquus internal of left side is contract, I try to work in the other position. So I work in the local muscle, but also in the more superficial muscle to keep better posture. And I take measurements before and after the training. If I can try to take measurements. If I can, because this depends a little bit the morphology of your patient, because sometimes here it's very easy to see images with the ultrasound, but normal life could be a little bit more challenging. Yeah, normally I work with athletes, so it's easier, but with people, more sedentary people, could be a little bit more difficult. If I have MRI, I use the MRI. So I take measurements and to see if there is any relation with my clinical examination, for example. And this way I can focus local muscle, but also superficial muscle if it's in according with the clinical examination.
What about the repetitions and home exercise? And when do you say to the patient that she can exercise at home? And the second question is, what do you expect in what time do you expect that things will change in function and in pain? So
normally I try to teach to my patients that it's better to spend several times per day on the exercise, not just lying down, but also more functional, because I would like to educate them to move better. So at the beginning, I like to spend a few minutes explaining that the problem is a poor control of the movement. So to improve the movement, we need to a little bit focus during the day. and we perform the exercise to optimize the learning. So if it's possible, but normally people ask me, okay, so how many times per day? So normally I ask them to do a couple of times per day, around 5-10 minutes.
Directly after the first session already, or do you say, no, I want to check if she or he can stabilize in one position, and then I say, okay, you can try it at home, or you...
So I work once per week with the patients, so once per week or once each 2 weeks. And so I try to be, if it's possible, very focused on the, in according with my clinical examination, if I can find that the poor control is in that direction, I try to start as soon as possible in that direction.
Okay, so I believe there are no questions anymore. Then Enrico, thank you for your interesting demo.
Okay, maybe I just last thing to say to Frank.
Yeah.
So normally I like to motivate my patients if I can. It depends about the interview. I try to say that we will work together 5 or 6 times, once per week, and after we will decide if we go on, because I explained that my treatment is linked with is teaching exercise, so they need to perform at home. See, if they cannot perform, maybe it's not, my treatment is not the best one for them. Maybe they need to be with physiotherapy 3-4 times per week, checking every time the movement. So yeah, normally more than 5-6 sessions I don't perform.
No questions? Okay, Enrico, then now I really want to thank you for your interesting demo. So a big applause for Enrico.